think we should, we'll get going. So I wanted to thank everybody for joining us here for the GBinsight Genetic Medicine webinar series. Today we're excited to have Dr. Christie Ballantyne give us a presentation titled, "Is there evidence for expanded genetic testing and evaluation of patients with severe hypertriglyceridemia?" Some quick housekeeping first. So I have a few minutes at the end of Dr. Ballantyne's presentation for Q&A. Use the raise hand function, the button at the bottom to ask your question, or if you want to offer a comment. We'll try to get everybody's questions, also be cognizant of Dr. Ballantyne's time. This webinar is being recorded and a copy of it will be available on the GBinsight webinars website within a few days. So just a quick intro. Dr. Ballantyne doesn't need an introduction, obviously, but Dr. Ballantyne is the Chief of Cardiology and the Director of the Center for Cardiometabolic Disease Prevention and Professor of Medicine and Genetics at the Baylor College of Medicine. He's author of many peer-reviewed articles and textbooks in clinical lipidology and cardiovascular disease prevention and management. I'll let you take it away, Dr. Ballantyne.
Thanks. Get my slides up. Okay, so let's start off. Right now, there's a lot of genetic testing for high cholesterol for suspicion of familial hypercholesterolemia. There's a lot less that's been being done for high triglycerides, and the current recommendation has been if there's someone is suspicious of familial chylomicronemia syndrome, that one look for the canonical the biallelic pathogenic variants, so LPL, ApoC2, ApoA5, LMF1, and GPI-HBP1. This is a rare situation. There's a clinical presentation, usually early onset, severely elevated triglycerides, not responsive to medications. The only one that's been approved is in Europe, not in the United States, for anasorsen with this disorder. So if we look at the most recent recommendations by the National Lipid Association, it points out that when you see very high triglycerides, so severe hypertriglyceridemia, it is usually polygenic. It's frequently not pure familial chylomicronemia syndrome, what we would call multifactorial chylomicronemia syndrome. And so it's important how high are the triglycerides is the first step. But there is a very strong genetic aspect to this. And so even in the guidelines, you should screen other family members to see what their triglyceride levels are. So let's go over a little bit of some of the definitions, but we talk about severe high triglycerides as being over 500, normal being less than 150. This is not a rare disorder. It's not common. It's about 1% of the population. More common, obviously, with comorbid conditions such as diabetes, hypertension, metabolic syndrome. The acute concern is usually that of pancreatitis, particularly when you get well over 1,000. And then lifestyle is very important here, along with the pharmacotherapy. And these people have, and particularly in the postprandial state, lots of chylomicrons. Most of them also have increased VLDL. It would be what we call a type 5 hyperproteinemia by the old-fashioned classification. Pure chylomicronemia is a type 1, and that's much less common. So what are the definitions? Well, you know, if you look at it, very high is over 500. Now, when you get into people talking about severe, the number that's usually used is 1,000 in the United States. That's because it's a round number. And in Europe, it's 10 millimoles, which is about 880. So that's when we talk about extremely severe. But over 500 is considered very high triglycerides. So it's a spectrum. So normal population less than 150. People higher that, you have the group that's in this severe zone. We'll go with the European number here, which is 885, or that's basically 10 millimoles. Now, out of that, what's very rare is to be truly we say monogenic, but it's really now, I think we'd call it biallelic with this. These people are extremely elevated. You have to have 2 mutations with it. And it's somewhere between, 1 in 300,000 to 1 in a million with it. So this is the most rare. What's much more common is this chylomicronemia multifactorial. And so this is, the majority of people is what you're going to be seeing here. So this is, 20 times more common than the pure FCS. So 95% of the people are 7% are going to fall in this category here, multifactorial chylomicronemia when you see a severe triglyceride. So we'll talk more about this group, distinguishing these top 2 groups. And it turns out that also, even in that zone of, over 500 or even going down to 300 or 400, you see there's a very also strong genetic components in these people with it. Now, people with normal triglycerides can have some SNPs or a pathogenic variant, very good lifestyle, doesn't show up much. So FCS is what's really rare. And what's more common are going to be mutations in those genes, other genes though too, which we'll talk about, but also multiple SNPs, which individually may have small, but when you combine them with a pathogenic variant, can have much more severe elevations of triglycerides. All right, so what we think about is the key issue is lipoprotein lipases, lipolysis of these triglyceride-rich lipoproteins. And so you can have deficiency in LPL, ApoC2 is important, ApoA5 is important, LMF1, GPI, HBP1, all of these are important for how lipoprotein lipase works. So these are the canonical genes that we are most commonly focused on in regards to this activity. And if you have 2 defective copies or combination of these genes, then you end up having very severe triglycerides. Now, what's the acute risk? The acute risk is pancreatitis. And this shows that as you move up on your triglycerides, the higher they go, the greater the risk is for pancreatitis. This is a log scale increase in risk. And so, and pancreatitis, not only painful, but individuals who have pancreatitis due to severe elevations of triglycerides tend to have worse, the most severe cases. And I've had some people, they end up in the ICU for a long time, they get ARDS. I've had 1 death from this. So it's a very serious situation. Now, it turns out that not only is there a risk for pancreatitis, but there's also an association of high triglycerides with increased risk for coronary heart disease. This is, some different population study. And this is kind of a slide showing about the problem that comes up is that people who have pancreatitis due to severe high triglycerides are more likely to end up with a outcome that's, persistent organ failure, need for ICU, pancreatic necrosis, more common in these individuals. Triglycerides over 1,000, 17 days median hospital stay versus 7 days, something we very much want to prevent. And there's also the concerns about individuals, and particularly in some families, you see that they have high triglycerides and increased risk for heart disease. Copenhagen City Heart Study showing the same thing, triglycerides in this range of over 500. There's an increased risk for coronary heart disease. Why do they get the risk of cardiovascular disease? We learned more about that triglyceride lipoproteins are atherogenic. The genetics have shown that people who have these defects in lipolysis have increased risk for coronary heart disease. There's an association between triglyceride lipoproteins and inflammation, higher levels of inflammatory factors. They end up having changes in their LDL particles. They have small dense LDL. They have low levels of HDL, changes in HDL particles. You get increased ApoB, increased particle numbers of small dense particles. There's lots of ApoC3, which may be pro-inflammatory. As I mentioned, lots of genetic data now that these are in the causal pathway for it. Okay, so it's a complicated disorder, and what we were looking at here is basically, if you were to look a little more systematically at variants, pathogenic variants in a slightly wider set of genes. We've been using a panel from GBinsight, and that we get a report back that talks about pathogenic variants. And it also gives information on a polygenic risk score. And this is, once again, a little bit broader one. This is a paper by Drone, but this has been looked at by other groups. And they've shown that people with who have heterozygous variants and polygenic risk scores tend to have higher triglycerides with it. What hasn't been looked at is also the risk with pancreatitis. So this was an opportunity for us. There's a few lipid clinics that we were working together and seeing how do we use genetic testing in our patients. And we've been using genetic testing for people with high cholesterol, high triglycerides. Also, if you have a very low level of LDL, this is also informative. And so the reports come back and they will talk about a pathogenic variant. Here's an example. Pathogenic and likely pathogenic variant in LPL. Individual is heterozygous for this. And then there's also a polygenic risk score that comes back. And here's someone that had a 99 percentile in terms of a polygenic risk score. So, and we'll show you some examples, but pathogenic variants are going to be less common. They have larger effects associated with a high triglycerides. This was a 34 SNP PRS for high triglycerides. They were weighted and scored for the hypertriglyceridemia pathway. So we looked at if individuals had one of these or both of these in terms of it. So this was looking at individuals who had elevated triglycerides, so they were over 200. And this was the breakdown of the 187 individuals in the 3 lipid clinics. And you can see is that the people in the severe range, this was the highest value of over 1,000. For these groups, the median for the highest value was 2,850. So it's quite up there. Then the group that was 579, they were 21, and 108 in the moderate zone here. Not unexpectedly, what we see is a lot of diabetes in the severe group that was increased in frequency. You can see there's a lot of pancreatitis here. At least one episode in 35 out of the 58. And these are lipid clinics, and the people we get referred tend to be referred to us because they've had high triglycerides and an episode of pancreatitis, and it is a good reason for referral. Now notice the pathogenic variants we saw in 36% of these individuals. A high PRS was also in 36%, and there were 16 individuals who had both had a pathogenic variant and a high PRS. So much more common than in the groups with moderate or severe elevations. This is the group that was very severe. Well, what were the outcomes? If you had, our reference group was no pathogenic variant and a low PRS. So the group that had a pathogenic variant and a high PRS, this was in terms of having very severe high triglycerides. 89% had very severe triglycerides. 61% had an episode of pancreatitis. So these were, even in the model that adjusts for triglycerides levels, it was still significant. And we think, we have only triglyceride levels at certain time points. We didn't have many time points, but how this makes sense is that if you have a pathogenic variant and a high polygenic risk score, you not only have severe elevations, most probably they are less responsive to diet and exercise and medical therapies for it. So you end up having your area under the curve. If we were somehow to be able to measure that, this would probably drop out, but you don't catch everything with a single measurement in terms of, we usually measure people in the fasting state, not the non-fasting state, and they're going to have even more severe elevations in the non-fasting state. So this group was particularly high risk, having very severe levels of triglycerides along with increased pancreatitis. That was actually the sampling. Now, part of what comes up is if we take a look at this, yes, LPL is the most common, but the other things that were mentioned in there were C2, GP, HBP1, LMF1. These were also found in these patients. ApoA5 is very important in terms of triglyceride metabolism, but ApoE is also, and there's some other genes in here. And one of them, in fact, which is to me very interesting, is the PPAR gamma. This was a patient actually in our clinic, had a PPAR gamma mutation. And when I was very surprised because this was at the time was being reported in 29 people in the world. But it's just, I think it's just because people haven't been looking for it. And I talked to mental neurologist before we started here, and he said they've seen that many cases just in their data set. So, if you don't look for something, you don't find it. And I think this having a little broader list of genes that are known to affect triglycerides and looking for pathogenic variants provides us some extra information. Okay, so I'm just gonna, this was just to quickly cover the area. So what do we find? That there's we have what we call it familial chylomicronemia syndrome. But we found out that this other group of people that it's multifactorial chylomicronemia syndrome, that if you had a pathogenic variant and a high PRS, you had the worst triglycerides and you had a very high risk for pancreatitis. Now, that is all inherited. So we call it familial, but basically there are many people with MCS that have a unfortunate genetic inherited profile that puts them at very high risk for severe triglycerides and pancreatitis. Now, what difference does that make? It makes a difference in regards to emerging therapeutics. And let me just show a couple slides on that. Now, this was volanesorsen. It was a drug that was approved in the EMA, not in the United States, because there was a problem in terms of side effect with higher dosages. But this worked even in people who were complete nulls for lipoprotein lipase. So they had biallelic true FCS. Here was a study with evinacumab. This is a monoclonal antibody to ANGPTL3. This was also effective in people who had MCS, but were not null. If you were null here, this is without any lipase. This is biallelic genetically confirmed FCS was cohort 1. Cohort 1 did not respond to this therapy. So severe triglycerides, different genetic basis, differential response to two emerging therapies. All right, so let me wrap it up here. We found that if you had a pathogenic variant and a high PRS, this identified a group of people who had the most severe triglycerides, also the greatest risk for pancreatitis. Now, the novel medications, such as those targeting ANGPTL3 and ApoC3, are being developed, but it turns out they don't necessarily work in all the individuals in the same way. So there's two things. One is a differential response. The other one, though, is who should get these therapies for it. And I think that, the individuals who may need this therapy the most may not be just people who have our classical terminology of FCS. And this is an issue that comes up as we've expanded our genetic knowledge, is we have old terms, familial chylomicronemia syndrome, that somehow implies that somebody who has, maybe they don't have just pure chylomicronemia, maybe they have MCS, they have a pathogenic variant, a bad polygenic risk score, they have very severe triglycerides. Well, all of that is hereditary for that individual. So that means it is familial. It's their genetics. So I do think that that individual would have the greatest benefit from a new therapy because they have the most severe condition that is hereditary, in addition to the very rare people with FCS. So I do think that as we get more genetic data on our patients, it will help us to be more precise in deciding which patient should get which therapies as we move forward. So I will stop it right there and stop sharing and open it up for any questions or comments in our audience.
Yeah, excuse me, once again, yeah, if you have any questions or comments, just use the raise hand button on the bottom, and Dr. Ballantyne will get to as many of them as possible. Let me start, Dr. Ballantyne. I have a question while other people kind of muster up some courage. You mentioned kind of the differential between true FCS and right now it's kind of done clinically. One slide you mentioned though that risk of heart disease is less so in people with biallelic. Can that be used clinically in the decision-making process? As far
what ends up happening with FCS, traditionally we think of it, you get at a very young age, you get pancreatitis, your triglycerides in 1,000. You don't get heart disease in childhood like we see with homozygous familial hypercholesterolemia. And that's probably because there's less conversion of some of the particles into LDL particles because there's such bad lipolysis. However, it does turn out that even with FCS, if you have diabetes, there's some increased risk for heart disease. But I do think that there are some of the people who have MCS, it's a double whammy. Not only do you have an increased risk for pancreatitis, I think many of these people also have an increased risk for heart disease. Because in a way, being able to convert more of these particles into LDL, when you have a type 5, you got chylomicrons and you have increased VLDL, but they also have LDL particles, lots of small ends LDL, they got low HDL. So, I think it's also a bad situation, kind of a double whammy, because you may end up, people tend to focus just on LDL cholesterol in terms of risk for heart disease. They don't focus much on these triglycerides lipoproteins. There needs to be more focus on that. It's an area though where it's a lot of movement, a lot of excitement about, understanding more how do we reduce risk in people who have triglyceride lipoproteins.
Yeah, I'm just going to offer one thing. That seems like the genetic data, looking at the population genetic data, seems to support that as far as heterozygous carriers of these triglycerides.
So that's exactly right. If we now look at the genes involved with triglyceride catabolism, it's showing up very consistently that they're associated with heart disease. So I do think it's going to be important that we get more information about these individuals and treat them more aggressively. Particularly, we have some pretty decent therapies right now, but the ones that are on the way look to be even more effective than we have right now. For it should be some new opportunities. But we don't see any of the problems that we saw with platelets, with the early generation ASO, with the newer things in development for siRNAs and ASOs. We are not seeing any problems with platelets. So I think we're going to have some much more effective therapies in the near future. In the meantime, it's also is that in terms of lifestyle, you have to be incredibly strict with pure FCS biallelic. It's really, really tough for individuals, and they pay a heavy penalty when they, they drift off, because you can get an episode of pancreatitis.
Seems like we have a shy audience, but one
There's
more question
there's a question.
Okay, yeah, you want to take that?
Yeah, so in terms of omega-3s, besides the VASIPA for triglyceride lowering, it turns out for triglyceride lowering, the mixture of EPA and DHA is at least as effective as pure EPA, which is VASIPA. It's probably a little more effective if you look at the data for that. So for triglyceride lowering, you don't have to use EPA. Now, if you're looking at cardiovascular risk reduction, the only place we have seen that is with EPA. EPA, like the other therapies for the biallelic FCS with no LPL activity, doesn't work. So in regards to alcohol, alcohol can cause pancreatitis by two mechanisms. One of them, I think, is direct toxicity. The second mechanism, though, can be through hyperlipidemia. And so this is what we have seen is that this is one reason why do our guidelines called over 500 is, severe hypertriglyceridemia. It's because if somebody comes in fasting into your clinic who's running 600 or 700, remember, that's the best number they're going to have all day long. That was after an overnight fast. What we have seen is that basically individuals who have diabetes or have postprandial lipemia is that not only does it go higher, so someone might be 300 in the postprandial state, they're 600. It goes higher and it stays up longer. So just imagine you eat breakfast, instead of starting to go down at 3 or 4 hours, it starts to go down at 5 or 6 hours. What does that mean? Well, if you eat breakfast at 7, what happens 5 hours later? Lunch, second fat load. And then what happens after that, 6 hours later? Dinner. Now, if you want to really see that something spectacular, you combine alcohol with a high fat meal. And now that person who in the morning might have been 600, if they're at Friday evening after, eating some bad meals, they may be 2,000 or 3,000 if they had a bunch of margaritas and beers and chips and, enchiladas. So yes, alcohol, particularly people tend to eat and drink and binge, unfortunately, all at once. So you really can get into some severe high triglycerides. And that's why Scott Grundy kept that, because if you're running over 500, it's not that hard for some people to shoot up into the 2,000 or 3,000. Another question about, so this is an interesting one. If we take a look in different populations, this was reported in the paper by Drone that in fact, there were, if you looked at very high triglycerides, more at a severe level over 1,000, you tended to find pathogenic variants and high PRS more frequently in Hispanics. We had limited numbers, but we saw the same trends with it. So I think this is something that's very interesting, and it's the same thing even for the, for example, pure FCS. They used to say it was LPL and C2. And then we had one of the first patients with GPI HB1, and she was South Asian. And I think that's actually more common in South Asian. So I think sometimes as we get into larger diversity, we end up seeing pathogenic variants that are enriched in some populations, and then also polygenic risk scores. And this is one of where the field is. So the polygenic risk scores are a little tricky. For example, with LPA, the variants associated with high LPA in European ancestry in Hispanics were associated with lower LPA, and they're more common. I know many of y'all are working on the Kringle repeats to improve that. So I think we have some work to do to improve polygenic risk scores. And the point you're making, it is a very good one, is that how do we look at this in different groups with genetic diversity? It's a very good point. And there probably are going to be more and more things that we find as we explore this. As we get more data.
Do you have time for one more, or?
Yeah, sure.
Okay, all right, let's call this our last one. So do individuals with mild hypertriglyceridemia also have genetic predisposition to increase TG levels?
And so that's also the case, that they've shown that before, that even in that zone of over 200, we would call that increased triglycerides, or 150 to 500. There's also an increase in terms of bad SNP scores, polygenic risk score, or some increased frequency in pathogenic variants. So this is the tricky part, is that, in a family, and we see this sometimes, that someone, they ask, well, I had borderline high triglycerides, and I don't know why now they're totally out of control. They may have had a very good lifestyle at one point in their life, and as they get older, they got overweight, they started drinking, they had other things that came up here with it.
Okay.
So the last one here, monogenic hypertrophy, we know is extremely high. So this was about the issue is, so this was the point here, is that monogenic hypertriglyceridemia, or what we would call now biallelic familial chylomicronemia syndrome, is very rare. And you may never diagnose a case of that. What ends up happening is that if you have a lipid practice, you are going to see cases of severely elevated triglycerides. That's who gets referred. And many of those people will vary in their ability to respond to a medication. If you have somebody who has a pathogenic variant, not two of them, just one of them, and a high polygenic risk score, what we have seen is that those people are most likely to have pancreatitis. They have the worst triglycerides. So they're going to need, the best possible therapies. This will get much more important in the fairly near future. We're going to have some new therapies available for such individuals, but they're also going to need the strictest diet. And I think sometimes even they just understand that it's genetic, they're going to have to work harder with it. One thing is that we've always used as the trait, people get it in sports. And I always use the example of, I live in Houston. We've got a great baseball player named Jose Altuve. Height is one of the strongest genetic traits. So when he went to the tryout camp in Venezuela, they sent him home. They said, you're too short. You'll never be able to play baseball. But in sports, people get it. Okay, if I'm short, I'm going to have to try harder to do everything right. I'm going to have to be smarter and try harder. And so the guy, fielding, stealing bases, hitting, complete ball player, but worked his tail off. Well, the same thing's true in life. If you've got a genetic disorder, you got to play it smarter and you got to work harder. So I think it's very helpful for people to understand that right off the bat. If you've got bad genes, life is not fair. But it's just, you understand this is my situation and you need to work at it. I've got bad genes. So, I got to work at it very hard with it, but I'm fortunate that I know that, and I can also have great, therapies and medications that I can take to reduce my risk.
Well, be cognizant of your time, and I think we're going to end it. So I wanted to say thank you very much, Dr. Ballantyne, for presentation, and for other people for joining, for asking insightful questions.
Okay.
So
thank you very much.
Thanks, Dr. Ballantyne.
Bye.
Have a good one.